Peritoneal dialysis utilizes a patient's peritoneum as a membrane to exchange fluid, electrolytes, toxins, and waste byproducts with the blood in patients with chronic kidney disease and end-stage renal disease. The benefits of peritoneal dialysis compared to hemodialysis include more gentle fluid removal with low risk of metabolic imbalances, as well as quicker initiation of dialysis. A peritoneal dialysis catheter can be used 2 weeks after placement to allow for the exit site and subcutaneous tunnel to heal. However, the catheter may be used within hours of placement if volumes of instilled dialysate are kept low and the patient is kept in a supine position to minimize risk of pericatheter leaks. The ideal candidate is a patient with a desire to perform his or her own care. Other beneficial characteristics include some residual renal function and minimal or no prior abdominal surgery. The only absolute contraindication to treatment with peritoneal dialysis is the lack of a peritoneal membrane. Potential barriers could include peritoneal scarring and adhesions, anuria, large patient size, ostomies, large abdominal wall hernias, and acute inflammatory processes. Peritoneal dialysis catheters can be placed laparoscopically when feasible. After insufflation, the catheter is introduced in the paramedian position through a trocar and positioned in the pelvis in the rectovesical or rectouterine space. The deep cuff is secured above the peritoneum and a subcutaneous tunnel is made, leaving the superficial cuff 1 to 2 centimeters deep to the skin. Dialysate solution is allowed to flow through the catheter into the abdomen and dwell for several hours. The dialysate usually consists of electrolytes, buffers such as lactate or bicarbonate, and a high percentage of dextrose to ensure hyperosmolarity. Solute and waste product clearance such as urea and creatinine occurs by diffusion from plasma to dialysate along a concentration gradient, whereas ultrafiltration and removal of fluid occurs due to osmosis, driving fluid from the peritoneal capillaries to the hyperosmolar peritoneal cavity. The most feared complication of peritoneal dialysis catheters is peritonitis. This can be secondary to the catheter from contamination with skin bacteria during exchange or spread from exit site or tunnel infection. Peritonitis can be secondary to an intra-abdominal or systemic process as well. Symptoms include abdominal pain and tenderness on exam and potentially systemic symptoms of shock. Dialysis fluid may be cloudy and sent for cell count differential, gram stain, and culture, and suspected with an elevated white blood cell count with a differential of greater than 50% neutrophils. Diagnosis is confirmed with a positive culture and treatment is with intraperitoneal antibiotics. Non-infectious complications include pericatheter leakage, catheter outflow failure, abdominal wall herniation, catheter cuff extrusion, and intestinal perforation. Pericatheter leakage can irritate the skin and increase the risk of infection. Management is usually accomplished by decreasing the dialysate volume. Catheter dysfunction from outflow failure is most often due to constipation, and an abdominal X-ray can identify any kinking or tube displacement. Abdominal wall hernias should be repaired at the time of catheter insertion. Erosion of the catheter cuff to the skin may be a sequela of exit site infection or excessive superficial cuff placement. Cuff shaving or catheter removal may be required in the presence of infection. Intestinal perforation can occur at any time after catheter implantation because of direct injury or weeks to months after placement because of bowel erosion. Signs of perforation are feculent or bloody dialysate, dialysate retention, diarrhea occurring after dialysate instillation, or gram-negative peritonitis.